Thank you very much. Hi, my name is Sunpil Hwang. I'm from the North Alabama Medical Centers. This is the second case I'm gonna present. This is about a rare presentation of metastatic sclerosing epithelioid fibrosarcoma with spinal cord compressions. I'm gonna give some brief history of the patients and how he presented to the ER. This patient is a 68-year-old male. He has past medical history of skin cancer removal on the left flank in 2019. At the time, the pathology was done and it shows sclerosing epithelioid fibrosarcoma, and the PET-CT scan with bone scan after a year was normal. It did not show any sign of recurrence or any sign of metastatic lesions. This time, the patient presented due to worsening back pain. He has a history of weight loss around 25 pounds over the several months, and he also complained of mild stomachache, which was more located on the lower area. On physical examinations, notably, the patient had bilateral lower extremity weakness. It was 2 out of 5, and the patient had it is not a true tenderness, but mild discomfort on the lower abdominal area. So this is the initial lab of the patient, and CBC were quite unremarkable. BNP showed some moderate amount of hyponatremia, but the patient was not encephalopathic, did not have any other symptoms. LFT was unremarkable for any hepatocellular disease. Procalcitonin was 0.3, LDH was elevated around 300 area. So this is the initial imaging of the patient. Since the patient had some vague stomachache and which was not consistent to any kind of like disease, so we did abdominal CT. And I want you to actually focus on the vertebral body. As you can see, it's not a regular vertebral body. It's actually showing some metastatic lesions, some demineralization, some lytic lesions. It's all indicating some possibility of metastasis. So considering the patient's symptoms, imaging finding, and also history of recent cancer, we started IV dexamethasone to cover the metastatic cord compression, and also neurosurgery, hematology, and oncology were consulted. On day 3, the patient went to thoracic and lumbar MRI. Just for your information, this patient had a claustrophobia, so he needed some time to decide for the MRI. That's why the MRI was a little bit delayed. So on the next slide, you can see the patient's MRI result. The one on the upper one is actually from thoracic area. It shows multiple metastatic lesions. The most prominent one is actually on T6 level. The metastatic lesion actually extending to the spinal canal, compressing the spinal cord. If you see the spinal cord closely, you can see some dark mass compressing the spinal cord almost completely. And the lower one is from the lumbar spinal cord. It also shows multiple metastatic lesions. The most prominent one is T12 and also L2 area. If you see the vertebral body, you can easily pick up the metastatic lesion on the T12 and L2. So since the patient is actually having metastatic cord compression, the patient underwent emergent radiation therapy. And we also talked with the neurosurgery, and since the patient had multiple and extensive cord compression, the surgery was not ideal in this case. So the patient underwent palliative radiation therapy, and after 2 days later, the biopsy was done at the T6 vertebra body. The lower one is actually the imaging of H&E stain of the biopsy. It shows some cord or sheets of monotonous epithelioid cell within a dense collagenous background. And the right one is the stain of MUC4 stain of biopsy. MUC4 is a highly sensitive and specific marker for fibromyosarcoma, and you can see there is a loss of positive signal from this stain. So with all this imaging and the biopsy result, the patient was diagnosed with high-grade sclerosing epithelioid fibrosarcoma. After finishing 5 days of radiation therapy, the patient was discharged to the rehabilitation center for further physical therapy. He had a further appointment with hematology and oncology for further chemotherapy. This is quite interesting case considering the rarity of this cancer. The sclerosing epithelioid fibrosarcoma is extremely rare cancer, and also he actually got all treatment for this cancer 2 to 3 years ago before presentation, and 1 year follow-up. 1 year imaging follow-up actually showed cleared out the cancer. However, the patient presented with the metastatic lesion of the same cancer again. So there are 2 points that I wanted to emphasize from this case presentation. The one is sclerosing epithelioid fibrosarcoma. As I mentioned, this is extremely rare soft tissue tumor. So we don't know the exact incidence because it has really low reported cases. It can manifest at any anatomic site. Usually the local recurrence is around 30 to 53%, and distant metastasis rate is 20 to 80%. As you can see, the number is quite a variety of range. However, it is quite a good amount of numbers. So the patient, whoever had this sclerosing epithelioid fibrosarcoma, are needed to be followed up more carefully to pick up any earlier sign of recurrence or metastasis in the future. Usually the treatment is based on surgery, and also the chemo or immunotherapy can be opted. The other point that I want to mention is about metastatic spinal cord compression. We actually see this quite a lot in the hospital settings. It's one of the oncological emergency requiring urgent management. The patient usually have lower back pain or any kind of neurological abnormalities. If this happened on the cauda-equina level, the patient also can have some cauda-equina syndrome. The treatment is prompt IV dexamethasone, which is really important. And after that, the decompression therapy can be done. Usually, decompression therapy is consist of surgical or radiation treatment. However, this is dependent on the patient's factors. So, like in this case, if the patient had extensive metastatic lesion, then is not ideal for surgery case. So the patient should receive radiation therapy. So it should be evaluated patients by patients in each case. So these 2 points are the one that I wanted to mention over this case presentation. And thank you for listening my case presentation. Thank you very much.